Okay, so today we're going to start to talk about allergies and related emergencies. So we're going to start with the immune system. So the immune system is a network of cells, tissues, organs. Everything works together to defend the body against attacks of foreign invaders. So think your germs, these tiny infection-causing organisms like bacteria, viruses, parasites, and fungi. Because remember, the human body provides an ideal environment for many microbes, right? We're wet, we're warm, they try to break in so that they can grow. It's the immune system's job to keep them out, or if we fail to keep them out, they will seek out and then destroy them once they've entered. So the immune system is innate immunity, which an organism is born with, and adaptive immunity, which an organism acquires following disease exposure. We'll talk about that more. So innate immunity, this is also known as genetic or natural immunity, is the immunity that one is born with. So this type of immunity, it's written in our genes and it offers lifelong protection. The innate immune response is fast acting and non-specific, meaning it does not respond differently based on the virus or the bacteria that it defends. The innate immune system encompasses physical barriers and chemical barriers. So, physical barriers, think of our skin, our eyelashes. Chemical barriers, those are defense mechanisms that can destroy harmful agents. So, our tears, mucus, our stomach acid. And then cellular defenses of the innate immune response are non-specific. So these defenses identify pathogens and substances that are potentially dangerous, and then it takes the steps to neutralize or destroy or kill them. Those are our macrophages. So they eat their giant cells, they come in, they respond to the foreign invaders by eating them up, neutralizes them, and kind of eats up all those bad germs. Adaptive immunity is an organism's acquired immunity to a specific pathogen. As such, it's referred to as acquired immunity, not immediate, and may not last a lifetime. So remember, adaptive immunity, it's not immediate, it does not always last throughout the organism's lifespan, although it can. And the adaptive immune response is marked by our T and B lymphocytes, our white blood cells, releasing many antibody copies to neutralize or destroy their target antigen, those foreign invaders. So let's talk about immunity, what the body possesses that keeps us safe. Innate immunity, physical barriers, like we talked about, our skin, chemical barriers, our stomach acid, cellular defenses, those macrophages that come in and eat everything up. Adaptive immunity is where our allergies can develop, but we have active immunity, so that's natural. So for me, I had the chicken pox when I was younger. Many of you probably have the chicken pox vaccine. Because I've had the chicken pox once, I'm not going to get it again. So I get immune to that. Or you can be given the vaccine so that you're not going to get that virus. Passive immunity, it occurs when an organisms receive external antibodies that protect against a disease. This protection can occur from mother to baby, pass through the placenta, or pass through breast milk, or by injection to defend against a specific disease. If you think back to COVID, when people were starting to get really sick, they would seek out those who have had COVID so that they can extract their blood and extract those antibodies to give it to those who seem to be most at risk for catching COVID really bad. So a healthy immune system, its ability to distinguish between the body's own cells, self, and foreign cells, which are non-self. When immune defenders encounter cells or organisms carrying markers that say foreign to them, they're going to quickly launch an attack. So the immune response is anything that can trigger this immune response is called an antigen. An antigen can be a microbe, such as a virus, or even any part of a microbe. Tissues or cells from another person, except an identical twin, also carry non-self markers and act as antigens. This explains why sometimes tissue and organ transplants may be rejected. In abnormal situations, the immune system can mistake self for non-self and launch an attack against the body's own cells. This results in autoimmune disease, such as arthritis, diabetes. In other cases, the immune system responds to a seemingly harmless foreign substance, such as ragweed pollen, and the result is an allergy. And this kind of antigen is called an allergen. So the immune response, those lymphocytes, those white blood cells created by our body to fight foreign invaders, begin as immature stem cells in the bone marrow, and then they grow into specific immune cell types, such as T cells, B cells, or phagocytes. Humoral immunity. So this is an antibody-mediated response that occurs when foreign material, antigens, are detected in the body. This foreign material typically includes extracellular invaders like bacteria, and this mechanism is primarily driven by those B cell lymphocytes, those white blood cells, and a type of immune cell that produces antibodies. So our body produces the antibodies after the detection of this antigen. Once the antibodies effectively bind to their target, they can either neutralize their target directly by blocking that normal antigen binding, or they can induce the recruitment of other immune cells like T cells and phagocytes that promote the antigen removal or destruction. So think B produces antibodies. Notice the B in both. The first time the body encounters a novel disease agent, its response is known as the primary immune response. When B lymphocytes or B cells encounter a new antigen, they're going to create antibodies specific to that antigen to destroy or neutralize it. Simultaneously, B cells create memory cells, which are a type of B cells, and that survives for decades and can detect that pathogen during any other subsequent exposure. And it takes the body time to create antigen-specific antibodies the first time, and therefore this response takes longer than the secondary or tertiary responses. So if an organism encounters the same pathogen a second time, the immune system's response will be faster and more robust than the primary because it's seen it before. So this is great for the chickenpox, preventing myself from getting the chickenpox again. But this also happens with allergens, and B cells create antibodies that have memory. And then these memory cells remember, and we'll talk about the allergic response again and how it can be dangerous. So another name for antibodies is immunoglobulin. So this is some antibodies created by our B cells and what they kind of look like. So we have IgA. This is abundant. It's found in our body fluids, think saliva or secretions of our respiratory tract, tears. We have IgE, which its function is poorly understood, but it may play a key role in initiating an early response. Then we have IgE. IgE is associated with an immediate allergic reaction. It's the villain of anaphylaxis. We have IgG. This works efficiently to coat microbes, speeding their uptake by other cells in the immune system. IgM is very effective at killing bacteria. And IgM is the first produced in the chain response to the allergen or the antigen. So humoral immunity. So you can see we have a B lymphocyte, and then you can kind of see these Y-shaped antibodies, and they're going to attach here. They will attach to a bacteria, and then they'll neutralize it. Or an antigen, like here, this might be ragweed, and it can precipitate or create an allergic reaction in your body. Antibodies commonly have this Y shape, and then they can easily attach and create that allergic reaction. So cellular immunity, so unlike humoral immunity, cell-mediated immunity does not depend on antibodies for its adaptive immune function. Cell-mediated immunity is primarily driven by mature T cells, macrophages, and the release of cytokines in response to an antigen. So think that can be from, a lot of people have reaction to medical tape. If you ever have to have medical tape after a surgery, cheap jewelry can cause a reaction on the skin. The main types of lymphocytes involved in C-mediated immunity, those include your helper T cells, killer T cells, and your macrophages. When a helper T cell finds an antigen presenting cell in the body, it releases a set of signals called cytokines, and these activate those killer T cells and macrophages to move to that site in order to destroy the antigen presenting cell. So the main difference between T cells and helper T cells is that those cytotoxic T cells destroy the virus infected cells, where the helper T cells secrete the cytokines to activate or regulate other cells in the trigger response, the immune response. So it might make a little more sense in this picture here. So here we have something has entered a macrophage. The macrophage has entered, rather, the infected cell. And then this antigen, this MHC complex, forms on the outside of the cell. And these are called antigen presenting cells. They then create the helper T cells and also these memory T cells, which release the cytokines, which is the chemical signal to those memory T cells to divide into killer T cells, which will then kill the infected cell or neutralize the infected cell. So this forms as well, fight off any cancerous cells that enter the body, and then see how it enters and it kills, and now the cell is dead. So this is what we want our body to be doing. So the allergic response. So allergic reaction uses the immune response against non-infectious substance, using the defense system inappropriately. Goals of the immune response: recognize the enemy, react and fight the enemy, and then remember that enemy for any future encounters. So first time an allergy-prone person runs into an antigen, such as ragweed, he or she makes large amounts of the ragweed IgE antibody. These IgE molecules attach themselves to the mast cell. And then the second time that person has a brush with ragweed, these IgE prime mast cells are going to release all of these chemicals. And this is what's going to cause that person the wheezing, sneezing, runny nose, watery eyes. And they're going to get all of those symptoms and side effects. So allergy, the allergen can be, it can be inhaled, swallowed, injected, etc., to become or have an allergy enter the body. So it's anything that's going to generate an allergic response. The most common, penicillin. And if you're allergic to penicillin, that usually means you're allergic to any of the psyllins. Bee or wasp stings, sulfa drugs, including sulfites, plants, chemicals. So this is why there's an importance of the medical history. We must know what they are allergic to, because there's drugs that might have cross allergenicity. Like I was just saying, if a person's allergic to penicillin, then you would have a cross allergenicity to all psyllins. And they may also be allergic to 10% of the time to cephalosporins. So we want to know, is it a true allergic reaction? You might have a patient say, oh, I'm allergic to amoxicillin because I got a stomach ache. Stomach ache doesn't always signify a true allergic reaction. Also, if there's no edema, there's no hives or redness, no skin reaction, then this could just be a psychogenic reaction. Their heart beating fast, after they've had local anesthesia. They might say that they're allergic to the local anesthesia when that's actually a normal response to the epinephrine that's within the cartridge. So we must have good questions to ask to know, is it really a true allergy, even though regardless, the patient's not going to want to get that substance that they've had that type of reaction to in the past. So what medications does the patient take for an allergic reaction? Do they take Benadryl? Do they have 3 EpiPens in their bag that they carry at all times? How do they react during the reaction? What are their signs and symptoms? Is it immediate? Does their tongue swell? Or is it something that happens 3 to 4 days down the road? You might hear parents whose children are put on penicillin and they don't notice, it doesn't show up on the skin until almost they're done with the antibiotic. So it may be 3 to 4 days down the road. And do they have a history of a prior allergic reaction in a dental setting? And then one more consideration. So we want to take into consideration family history of allergy. So atopic, this is a genetic disposition to develop an allergic reaction, such as allergic rhinitis or asthma, and you're going to produce elevated levels of IgE upon exposure to an environmental antigen, especially one inhaled or ingested. My husband has really bad seasonal allergies to pollen. My son, we know every time, as soon as the grass starts to grow, his face swells up, his eyes are swollen shut. He is very allergic to pollen. So immediate allergic reactions are more likely to die from anaphylaxis. So this is your history of an anaphylactic allergy. Think wasp or bee stings. If you're stung by a bee and you immediately swell up, your airway is closing, that's an anaphylactic reaction. So dialogue questions, which we kind of talked about. What are you allergic to? Describe your reaction. How long before your symptoms begin? What do you usually do about it? And your reactions in a dental setting. And have you ever been hospitalized due to an allergic reaction? How long does it take for that Benadryl to set in? So then we have different types of allergic reactions. So type 1 and type 4 are the most common in dentistry, with type 1 being the most life-threatening. Type 1 is your humoral IgE with that strong hereditary factor, most life-threatening, and reaction time is significant. Type 2, these types of allergies have to do with blood incompatibilities. So if someone's getting a blood transfusion, this can also be associated with autoimmune disorders. Type 3 is an immune complex disease driven by IgG serum sickness. And then type 4 is your delayed. So this is your cell-mediated, think contact dermatitis, repeated exposure of direct contact, say with latex gloves. So a lot of clinicians may develop this, especially previously when latex gloves were really common. Your skin becomes red, edema, the tissue swells. You may have vesicles that form on the skin, like little fluid-filled patches. Pruritus, which is itching. That's the medical term for itching. You can take something orally, but you may want to instead use like a topical steroid cream to decrease that inflammation, and then take an antihistamine to help with the itching. So contact dermatitis, which we were just kind of talking about. So this is a type 4 reaction, usually repeated exposures of direct contact. This can also be seen on the oral mucosa from dental materials. And then those signs and symptoms, that redness, edema, swelling, vesicles, almost like those little fluid-filled blisters, pruritus, which is the itching, and that's with the topical antihistamine, topical steroid. So you can see here, this is the skin, it's looking red. I don't see any vesicles, but it definitely looks like it would be itchy. So urticaria, commonly known as hives, and it's often accompanied by pruritus. So common with the itching. It's a vascular reaction, raised areas of erythema and edema, maybe mild and severe, maybe located just on the trunk of a body, but it also could be localized or localized, generalized, you can have it from the top of your head to the tip of your toes. If anyone's ever had hives, it is not comfortable. I broke out in hives not too long ago, and they couldn't figure out why. They were all over my body. They were very itchy. It was very uncomfortable. And with that, your blood vessels, they're dilating. You're going to see that redness. You're going to get that edema as the cells are trying to fight off that antigen, which is just an allergen, but the vessels become more permeable. So the fluid inside of our vessels is going to begin to leak, which causes that edema. That swelling is caused by that leaking in our vessels. This is a type 1 reaction. Oral histamine, Benadryl, I had to go on steroids to finally get mine to go away. Again, they never could figure out the cause. It was the strangest thing, very uncomfortable. But this is kind of what it looks like. So this here looks like one big kind of hive here. They can clump together, coalescing. That's the joining together, and then they get bigger and bigger, and they also move throughout the body. So like it might look like this one day, the next day, you might have a big patch here. Depending on the color of the skin, they might look pale or darker red, but they're not comfortable. So angioneurotic edema. So this is a localized edema. This goes deep, deep, deep into the deep dermis or subcutaneous submucosal tissue. So it's a giant form of urticaria, which is sometimes mistaken for urticaria because it resembles the condition initially. However, hives, your standard hives, is much more superficial. And this here is a huge signal when it's deep like that. So signs and symptoms, usually just one large single lesion with no defined raised borders. And it's often, now this is a big difference, there's no pain and no itching. So that's much different from hives. I can tell you hives are very itchy. The swelling can happen anywhere, but what happens if it's in your neck? So that may involve the larynx. It can compromise the airway. The swelling may also involve the lips and the tongue. They'll report that their throat feels like it's closing up. Common sites, though, are your face, your hands, your genitals. And if it's limited only to the skin, it's usually not life-threatening. And if it's on your face or your hands, or your hands or your feet, it's kind of far from the airway. So you can see the swelling here, the eye is closing, angioedema in the face, and this can be spreading to the throat and compromise the airway. But again, if we have it in the feet or the hands, the genitals, we're not so worried because the throat's far away. But if you're seeing the swelling in the face, that's when we're more concerned. So here's our treatment if the airway is not involved. So usually if airway is not involved, we want to keep them up. But for this, we want to keep them down while we're figuring out what the angioedema is there. Let me start again here. So treatment if the airway is not involved. Supine, we're laying them down. We're administering oxygen. We're monitoring their vitals. Now, falling blood pressure, this may be a critical sign. So we want to administer antihistamines, report substance and reaction to the physician. Now, if the airway is involved, we're still going to keep them supine, and this is because we're getting ready for CPR. So even if the airway isn't involved, we want them supine just in case. We're going to administer the EpiPen, and remember, it might take many EpiPens to have it be effective. So offices should always have at least 2. We're going to maintain the airway. We're going to administer oxygen. We're monitoring vitals. We're summoning medical assistance immediately, administering the antihistamines, and we're preparing to do CPR if there is a complete collapse of the respiratory system. Okay, anaphylaxis. So a severe and acutely life-threatening type 1 allergic reaction. This can cause death in minutes. Injection route is the route most likely to result in anaphylaxis and an allergic reaction. So if something is delivered by injection and the person becomes anaphylactic right into the bloodstream, we can't get it out. But say someone swallows a pill, that's easier to remove from the body, and we can have them immediately try and start vomiting the substance. Respiratory and circulatory difficulties occur together and early in the reaction. So the pathophysiology. So for any true allergic reaction to occur, the patient must have been previously exposed to the antigen. So they're exposed before the life-threatening exposure. This is called the sensitizing dose. So it's the initial exposure to the antigen, the immunoglobulins, those antibodies specific to that antigen and that person, usually atopic, the person with the history of allergic reactions, they have higher levels of IgG are formed. These IgEs are going to attach themselves to the cell membranes of the basophils and the mast cells in an atopic person. Remember, there's that genetic tendency to overreact, and this is going to create that overabundance of IgE. So after this sensitizing dose, so the sensitizing dose is their first dose, there is a latent period, so a sleepy period. This can be days, this can be months. And during this time, without us even being aware, the IgE antibodies are continuously being produced, and the patient is then sensitized to the specific antigen. So the challenge dose, allergic dose, so if we're talking bee stings, the first bee sting is that sensitizing dose, they might not have a reaction. The second time they're stung by that bee, this is their challenge dose, and this may result in an antigen-antibody reaction. This reaction causes the release of those chemical mediators of inflammation from the mast cells. They're going to spit out those chemical mediators and basophils. These mediators are histamine, and they're slow-reacting substances called SRSA of anaphylaxis, and are responsible for causing the physical changes in anaphylaxis that we see. So the chemical mediators, the slow-reacting substance of anaphylaxis, or those SRSAs, is a mixture of leukotrienes, LTC4, LTD4, and LTE4. The mast cells are going to secrete all of this during the anaphylactic reaction. This is going to induce inflammation, and it can be found in the basophils. So this induces prolonged, slow contraction of smooth muscle and has a major bronchoconstrictor role in asthma. Compared to histamine, it is approximately 1,000 times more potent and has a slower onset but longer duration of action. So we have vasodilation in blood vessels, so people are going to get red. Increased capillary permeability, there's all that increased fluid in our capillaries that it just begins to spill out. We get bronchoconstriction, which is a primary feature of anaphylaxis. Pain or itching in our nerve endings, that's urticaria. Erythemia, edema, dyspnea, pruritus. So again, the blood is flowing out of the capillaries and we have bronchoconstriction. This causes us to not be able to breathe. So signs and symptoms of anaphylaxis: skin reaction, which we talked about, that urticaria. We have GI reactions. People are going to feel sick, cramps, nausea, vomiting, diarrhea. This is basically the body screaming, get out, evacuate. It's trying everything it can to get this substance out of its body. Respiratory, that feeling of the tightness in the chest, the weight on the chest, cough, wheezing, dyspnea. You may see cyanosis depending on the color of their skin. Laryngeal edema, so swelling, resulting in a total airway obstruction. That's the most common cause of death in anaphylaxis. Cardiovascular, we have cardiovascular effects as well. So we have palpitations in our heart, tachycardia, hypotension, because the blood pressure is going down. We may have loss of consciousness, cardiac arrest, sweating, anxiety, restlessness. Our pipes, they're getting bigger because our blood vessels are filling and spilling out. And that's what's causing our blood pressure to go down. We're trying to get that blood back into the heart, which is causing that tachycardia because all of the blood is spilling out of our vessels. In some cases, signs and symptoms will proceed in this order. In other cases, the reaction is so severe that the signs and symptoms all occur at once, and the patient loses consciousness almost immediately. This is often the most fatal and difficult to treat. The most common causes of anaphylactic death: penicillin, bee, and wasp stings. Individuals with an atopic history are always more susceptible to anaphylaxis death than patients with no history of allergy. So types of anaphylaxis, treatment of anaphylaxis, which we kind of went over. We're going to summon medical assistance, supine position, initiate BLS. We're going to administer epinephrine. We need help to arrive fast. And again, we're going to administer that EpiPen multiple times, like we said before, because it has that short duration. The person can start to look like they're getting better, and then it's just going to immediately click back in and start again. We want to give oxygen. We're going to administer an antihistamine, steroids if you have them. Usually that's done, though, at the hospital. Rapid onset, so the person, like I said, is looking better, but then you may need to give more epinephrine. Hopefully kits are having more than one EpiPen in them. And then we want to transport to the hospital as fast as possible. So epinephrine, like we said, rapid onset, short duration. It's a functional antagonist, so it's going to produce actions opposite those caused by the histamines and the SRSA of anaphylaxis. It's going to produce vasoconstriction, so it's going to constrict our blood vessels to keep the blood in there, so that's going to get our blood pressure to go back up. Bronchodilation, so it's going to open our airway back up, and cardiac stimulation to keep the heart going. So additional meds for anaphylaxis: steroids to decrease inflammation. It also enhances the action of epinephrine. This, again, is usually sometimes done at the hospital. And antihistamines to block further action of circulating histamine, and it prevents reoccurrence of reaction. And this is kind of just in a quick nutshell of allergies that we kind of need to know. It's semi-in-depth. We can go much more in depth, but this is kind of an overview of anaphylaxis.